and happy to participate in this kind of boot camp series for you. So we're going to go through some kind of things that I think are really important to identify and approach the beginning steps of management, what I think is reasonable to think about and work with your teams on. Okay. So we're going to talk about chest pain, of course, and this is not a simple diagnosis at times, of course, which is why it brings a lot of anxiety and is dangerous. Um, we're going to focus on cardiovascular causes, but as you guys know, there is a large differential. And I would say the most common causes are going to be cardiovascular, GI related, musculoskeletal, and psychiatric. Okay. So those are going to be the most common causes of acute chest pain, especially in the hospital or emergency room setting that you're going to see. So when we talk about chest pain, I think it's really helpful to kind of focus on the history. Okay, history is super common in cardiology. It's very important, or is very important in cardiology, and it helps us differentiate the cause of somebody's distress. It's not perfect, but it's super helpful. Classic angina or chronic coronary syndrome is really characterized most often as a central or diffuse discomfort and pain or pressure. And what I suggest you ask the patient is for discomfort, because if you ask them about pain, they often say, no, I don't have pain. It just, is squeezing and crushing, right? Which kind of misses the boat. It's typically several minutes. It's not seconds in nature. It's really not present at rest, unless we're talking about something else. It's present with exertion and relieved with rest, okay? And it really doesn't change with positioning, moving your shoulders, rolling over in bed, things like that, right? We get a lot of referrals for chest pain that is positional, and it's not cardiac, okay? And it can be associated with dyspnea often and or nausea if it's really severe. However, I want you to disassociate the word of atypical chest pain, please, and think about pain that is not ischemic or not cardiac as in non-cardiac pain. Okay. So non-cardiac pain is going to be things that are often sharp, localized, it's fleeting, comes and goes, has no predictability. I saw a patient in clinic yesterday with one of your colleagues who has severe coronary artery disease, and he has pain that is reproducible and not cardiac. Okay. So I hope that's clear. These are two important points that I want you guys to understand, both in the hospital setting and in clinic. Okay. Now, acute coronary syndrome is different. Okay. So acute coronary syndrome can be and is most often from plaque deposition in a coronary artery, lipid-rich plaques, which are vulnerable, not completely clear why some plaques get disrupted and some don't. You have a thrombosis, some sort of platelet aggregation propagated by platelet activation, thrombin formation, fibrinogen formation, and cross-linking. And this causes an occlusion. This is something that happens over seconds to minutes and is not something that comes and goes. It can happen suddenly, like non-cardiac chest pain, but it doesn't go away. It's usually associated with persistent symptoms, often severe, often escalating, and unrelenting. Okay. So distinguish the atypical symptoms of things that come and go, no rhyme or reason, acute symptoms from ACS, which is a thrombosis, which gets worse and worse and worse, and often can last for many minutes or hours if they don't seek attention. Okay, so now that we've kind of covered the basics of ischemia, this is kind of your first case, okay? So you're on call, you're cross-covering, and the nurse tells you they look unwell. And so I would always keep that in mind when an experienced nurse says they look unwell. Okay, that's important. So once you get that page, what would you do? order aspirin and heparin because you know they have acute coronary syndrome, call the attending, order a chest X-ray, order an ECG, or order a troponin. So please take a few seconds and choose. So I
We're
get to
getting
choose
some
too.
good responses.
I don't see the results. Where
Okay,
do I
that's
see
because I
those?
haven't shared them yet.
Oh, okay.
Okay, we will end the poll, and here you go.
All right. Everybody ordered an EKG. I hope this is, how many responses did we get?
22 of, I think,
Excellent.
28. Yeah.
Excellent. Okay. So I want to get an EKG. And the reason why I want to get an EKG, because an EKG is a what's happening now test. It's not a what am I going to find out in a half an hour or an hour or two? That's a troponin. Okay. And so there's a broad differential for chest pain, so we're not going to be ordering heparin and aspirin. And I don't want a phone call about a patient unless I have some information and you yourself have personally investigated how things are going. So we're going to order an EKG. So that's great. Okay. So the second thing to do is print out the old ECG or take a picture on your phone. And then the third thing is go see the patient. Okay. Again, a history and physical is extremely important, along with an EKG for acute chest pain. Okay. So these are the things to think about as you're walking towards the patient. Is this an acute coronary syndrome, a dissection? Maybe it's pericarditis. Or is this just progression of their severe aortic stenosis and they're getting unstable? Okay, maybe they're admitted with decompensated heart failure from severe aortic stenosis, working up for a valve replacement. Okay, so you see the patient and their vital signs are clearly abnormal. The heart rate is slow, the blood pressure is low, their oxygen saturation is low, on a little bit of oxygen. And importantly, they look in distress, okay? So never have I ever seen anybody who has an acute coronary syndrome who's looking relaxed. Okay. So your initial impression, the nurse's impression about how they look is super important, and that's a skill you have been developing and will continue to harness. Okay. On exam, they're slow, but otherwise it looks pretty good. So you look at that EKG. Now, clearly it's not the same person. The heart rate here is a little higher, and I would love if somebody can put in the chat what they think the rhythm is and what they think the most pertinent findings are here. Or if somebody even better wants to speak up. I'm going to give you guys a few seconds. Either one or all of that information would be helpful. And then I'll go through kind of the critical factors. Betty in the team rooms want to pipe up and give us your thought about the pertinent findings and maybe the rhythm. We got one suggestion in the chat. Third degree heart block. Okay, thank you. This was a QRS. Okay. Oops, sorry. Okay. Saying Mobitz 1. Okay. Here's STEMI. ST elevations. Excellent. I like it. So let's talk about acute coronary syndrome, because that's what this person has, right? This person has inferior ST elevations. And when you guys talk about elevations or depressions, I want you to be thinking about the prior TP segment, okay? Not the PR segment, but the prior TP segment. And when you're dealing with the limb leads, so 1, 2, 3, AVR, AVL, and AVF, we only care about 1 millimeter ST elevation in contiguous leads, so in two or more. So we have inferior ST elevations, okay, in 2, 3, and AVF. We also have Q waves, okay, which you can see as well. So this person has an inferior ST elevation in mind. And importantly, you see some reciprocal ST depressions, which are also present in the anterolateral precordial leads. So this person has a inferior ST elevations. Now, if we get to the rhythm strips to help us determine what the rhythm is, then what I would suggest is that we focus on, okay, is there an association between P's and QRS's? Well, it is unclear because we're having multiple random drops of QRS's. It looks like there's a drop here, right? And then there's a drop here and a drop here. And we have some sort of a pattern. We have two here and then a drop. We have three here and a drop. We have three here and a drop. So this is what's called group beating. And so we have a PR interval here, which is a little long, but then something here that looks quite long. And then something here, oops, there's nothing there. And then we get our P, Q, or S. And so it gets narrow again. It gets longer, longer, drop, short, longer, drop. So I would say this is probably Mobitz 1, okay? And when you're in ischemia, you can get all the rhythms. It can be Mobitz 1, it can be Mobitz 2, or heart block. And if you have progressive inferior ischemia, you can progress to all the rhythms, including junctional rhythm with complete heart block. Okay. Excellent. Okay,
Dr.
next question.
Oh yeah, sorry, just one question. So I think someone had guessed for that EKG, like complete heart block. Just
Yeah,
for clarification, it sounds like you would expect to have like a marching out of both the QRS and the P waves, just not
yeah.
connected for it to be like complete heart block. Is that correct?
Thanks, Emily.
Yeah.
Yeah, when you get complete heart block, I appreciate that. The rhythm is driven by some other place in your heart, usually in the junction, the His bundle, or in the ventricular myocyte. And that is going to be a regular rhythm. Okay. And so you're going to get the P waves marching through at a certain phrase or rate, and then you're going to get the ventricles going through at a certain rate. They're not going to be related, and they're going to be just kind of overlapping each other as they go through. But the important point is a kind of a regular ventricular rhythm. So you should see QRSs which are regular and going through. Okay. And then if you could, sometimes it's hard on one single strip of an ECG. It's just 10 seconds, right? If you have more rhythm strips or look at the tele, you should be able to see P waves marching through. And I do think there's a relation between this P and QRS, this one, and this one. Although I would say it's not perfect. So if I had to put my money on it, I would say this is Mobitz 1. Okay.
Okay, thank you.
Yeah, thank you. Okay. So you get this EKG, this person looks ill. Your first move.
The interns are doing an excellent job with this sick patient. And we have 14 people, 15 that have responded. Okay, we're at about 18. Okay, I'm gonna end the poll.
Great. Okay. So I like these two answers. First thing is going to be you call cardiology, and the second thing is going to be you order aspirin and a heparin drip. Okay. I'll accept both answers, but those are the two most important things to do. Okay. And what dose of aspirin are we going to give? We're going to give a full dose aspirin, 324, 325, and they're going to chew it. Tastes bad. It's okay. All right. So you can even do both at the same time. But the important concept here is this ST elevation, MI, time is heart muscle. The further delay we get calling cardiology, getting cardiology in, getting them to the cath lab, the higher the mortality is. And it kind of goes up by minutes, really. For every minute's delay, the mortality goes up. It's actually a very well-oiled system from home to hospital. It's pretty chaotic hospital to cath lab. So your job is to call cardiology and stop all the craziness, focus on the patient, get them aspirin and heparin, and then get them to the cath lab. Okay. Unless they're actively hemorrhaging or are in for a major GI bleed, there's essentially no reason not to proceed. Okay. X-rays aren't going to be helpful. Labs are not going to be helpful. An echocardiogram's not going to be helpful. Okay. So get them to the cath lab and cardiology is coming in. Great.
We have a question. If this were a board's question, yeah, which one should we do?
Well, I don't think this would be a board's question because there's more than one right answer. So if the question, if you take out A, B, C, if you take out B, then the answer is A. Okay. Because I don't care what a troponin's going to tell me because if I have an acute coronary syndrome right now, it's not going to be positive for a while longer. Okay. Ideally, by the time you get the troponin back, they've already had a catheter in their body and getting their angioplasty and stents. So acute treatment of STEMI is important. Any other questions, Emily? Okay. All right. So ST elevations, especially in the anterior leads, are confusing. So I want to bring up V2 and V3 are often elevated, okay? And that's often normal. So they need to be significantly elevated 2 to 2.5 if you're younger, and if you're female, a little bit more than 1 millimeter, okay? And it has to be in 2 contiguous leads. Now, in the right setting, a new left bundle branch block is uninterpretable, and in the right setting of acute chest pain and diaphoresis, you can treat that as a STEMI. And then you should get and should look for reciprocal ST depressions, okay? All right. Those are the kind of important criteria to think about for ST elevation MI. In the interseptal leads, you're going to have higher elevations and contiguous leads. Okay, so we got to call a code STEMI. So you guys should pick up the phone, call a code STEMI, right? It's like a code blue. Okay. What meds? We're going to give them aspirin. We're going to give them anticoagulation. And then we're going to give them a second antiplatelet agent. Okay. Now, we're not holding up their cath lab transport, right? We're ordering these. We're talking to the stat nurse. We're saying, okay, we're going to give aspirin now. We're going to get heparin with a bolus. And then we're going to give them ticagrelor or prasugrel. These are potent antiplatelet inhibitors. They work very quickly. And that's the goal, is to inhibit platelet aggregation and activation. We don't want to be holding up for their ticagrelor or prasugrel because we can just give them in the cath lab, no big deal. So platelet activation, we want to be using aspirin. This is kind of older kind of concept of clopidogrel. Ideally, in this day and age, we want to be giving them ticagrelor or prasugrel, okay? And so we want to inhibit platelet aggregation, right? We want to give them anticoagulation with heparin, unfractionated heparin, because we want to limit thrombin activation, thrombin formation, and inhibiting that platelet plug. And they all work together and overlap, forming this plaque. Clearly, there's already a clot, but what we're doing here is we're not busting up the clot, but we're limiting propagation. The larger the clot is, the harder it is for us as interventionalists to open that up and to provide perfusion. Because even if you open up the vessel, the larger clot burden is the worst people can do.
Wait. La, la, la. We have a great
Oh,
question. Great question coming from UW. Does the choice between ticagrelor versus prasugrel depend on timing of the cath, or is it NSTEMI versus STEMI? Or I will add, is it what's available at your institution?
so I would say this is a moving target, okay? And I would not worry about that super detail. But this is a person who has a STEMI. They're going to the cath lab with planned PCI. So either one is good. For NSTEMI, technically it's slightly different. Okay, so you can give ticagrelor, and technically prasugrel is for only patients who get PCI. Um, there are some subtleties to that as well. If you're over 75 or have had a stroke, you don't want to give prasugrel. Okay, that might be on the boards. So that's a contraindication. All right. And if it's a STEMI, I would shy away from clopidogrel just because it's not as fast acting. And these two agents are going to be more potent and quicker. So either one is acceptable. Either one, if it's available, you can use. Sometimes at the VA, no, it's easier to get ticagrelor.
Okay, awesome. Thank you.
Yeah. Okay, so Mona B, right? How do we treat the patient as they're getting towards the cath lab, right? You're going to be wanting to be at the bedside the whole time, walking them through, making sure they're okay, making sure they're not having an arrhythmia or going into shock, right? This is kind of what I learned, which I think over time we've gotten more subtleties, which is important. Okay, it's not always, what are we doing here? Right? It's just not like a robot. We're just going to give them morphine and oxygen, right? Give them that beta blocker, IV metoprolol, 25 milligrams. Okay. So when we think about an MI, it's important to, when we start think about treatment, there is some importance on where the MI is happening. Okay. So we want to break them up to inferior, this lateral, and then this anterior septal region. Why does that matter? And these are kind of the leads at contiguous. Well, it matters because of an RV infarction, right? And so most of the time, the RV is going to be involved with a RCA STEMI. Now, it depends on where the occlusion is. If it's in the proximal portion of the coronary artery, it's going to involve the RV. If it's in the distal part of the coronary artery, it'll miss the RV. Okay. And so how do we tell? Well, all you got to do is just literally switch the leads over to the other side and look for ST elevations, right? And that's the injury current change that you'll see. And that's what we want to look for. So this is important because number one, when you have acute RV infarction, patients do worse. And number two, you probably don't want to use nitroglycerin, okay? They're going to need more preload than normal. So you got to be cautious about that, okay? So I would kind of go away from just rote Mona B because the treatment after you've activated the cath lab is aspirin and heparin, right? And then you want to kind of judiciously manage their chest pain. We're not going to get rid of it until we open up the vessel. But if they're in agony, you can give some morphine, nitroglycerin. If they're really hypertensive, you can give them some beta blocker, oral beta blocker, okay? If they're hypoxic, give them oxygen, but not just straight oxygen. Too much oxygen is always shown to be either not helpful or harmful. Okay. And then if for whatever reason in acute coronary syndrome they're developing pulmonary edema, you want to give them diuretics. Okay. Pulmonary edema causes people to be dyspneic, activates catecholamines, causes more ischemia, and you get a downward cycle. Okay, so this is just a cartoon showing that if you get a proximal RCA infarction, you're going to get that RV involvement, right? If it's more of a distal infarction, the RV is going to be spared, but you still might have some conduction disease problems in the AV node system or over here. So know that with an acute coronary syndrome, the LAD or the RCA can give conduction disease abnormalities, okay? Any questions about that case? So the important thing is to go see the patient, get an EKG, recognize that they're ill, activate the cath lab for a STEMI in all situations. And if you're wrong, that's okay, right? That's okay. Have a discussion with the providers, look at the EKG, even text them the picture maybe, and kind of review what you're seeing, okay? And it's okay to get two EKGs, right? So you don't always have to know the answer right now. Things change.
There was a question from the VA about the second antiplatelet agents and management.
Mm.
They said, what about patients who may need a CABG? Should we still give a second antiplatelet agent?
Yes. So the era of the urgent cabbage is fleeting, okay? Um, Especially in our institutions. Other institutions, this may be a little bit more common, but especially at University of Washington and affiliated hospitals, it doesn't happen really, okay? The reason to get an urgent cabbage these days is if you do a PCI, you do an angioplasty, and you dissect the vessel, and you can't fix it with stents. Then that's an indication for a emerging cabbage. And to be honest, you can get platelets. It's okay. So that's something that you would never know, right? And so it's more important to treat them like they would already 99% of the time. And if you're wrong, that's okay. It's not, the idea is they're going to get stents almost all the time. But I wouldn't worry about it. Okay, next case. This is a 67-year-old with non-coronary artery disease with a stent. He presents to the emergency room, retrosternal chest discomfort with nausea and diaphoresis. And before he even got there, he took his nitroglycerin because often people will have home nitro and they have chronic coronary angina or chronic coronary syndrome. So he did what he was told to do, which is the common. You take the 3 nitro and then you get help, okay? Because it often can mean something worse is happening. So he went to the ER. Hopefully he didn't drive himself. And he got some morphine and now he's kind of calmed down. Okay. So we're going to view the EKG. The chest X-ray is unremarkable. The labs are unremarkable, except his high sensitivity troponin is mildly elevated. And depending on the lab, but typically it's around 30 or 0.03, depending on what the lab is. Oh, okay, here's the ECG. I'm going to pause for a minute. And if someone is brave to see if they see anything abnormal. So what we see here is somebody with sinus rhythm, okay, an upright P in 2, and it's got a nice steady PR interval. It's a very regular rate, so this would be normal sinus rhythm. I'm going to hone in on the ST segments, and I don't see anything dramatic. Okay, so this is a pretty normal EKG. Okay, does that exclude acute coronary syndrome? No, because we already know this patient has an acute chest pain presentation with an elevated troponin. Okay, so on exam, now they're looking comfortable, they're hypertensive, okay, and their exam is otherwise unremarkable. Okay, maybe a borderline oxygen saturation, but not too bad. And so now that they're doing pretty well, you have time to chat and you get a history. This is important to review. Well, on second thought, I've been having this escalation of symptoms, and typically it's been resolving with rest. But, tonight it came on with minimal activity and it wouldn't go away. It felt like somebody was sitting on me or squeezing, and it was lasting for a long time with nausea and shortness of breath. Okay. And now what do we do? Well, there's always going to be a delta trope, right? That's what it's called. You get a change in troponin. Okay. So what happened to the troponin? Well, it went up. Okay. And so this is an acute coronary syndrome. Even though the ECG is okay, you can have very minimal abnormalities or even a really normal ECG. Okay. And so we're going to treat this person as an NSTEMI, right? And it's not unstable angina because the troponin is positive. And in this day and age, with high sensitivity troponin, true unstable angina is very uncommon, very rare, and maybe even kind of removed as an entity down the road. Okay. So this is a plaque rupture event, but we don't have ST elevations. So It's still chest pain, it's still acute coronary syndrome, but the ECG is kind of boring. That doesn't mean it's not an NSTEMI. And so we're going to use aspirin, and we can either use clopidogrel, prasugrel, or ticagrelor. Okay. Ideally, we can give heparin if it's going to be like Friday night and we're not going to get the cath lab going until Monday morning or wherever at your hospital. Lovenox is reasonable, but in general cardiology, we prefer heparin. So it's on, quick off when we puncture holes in arteries. Using Lovenox or other low molecular weight heparin agents really kind of increase the risk of bleeding. It's good for anti-ischemia, but in general, unfractionated heparin. And then we just treat the chest pain, okay? And this is where we're going to give the beta blocker. We're going to give them oral beta blocker and get their heart rate down nice and low to the 60s, treat their blood pressure, okay? I think an echo would be helpful, but really what we want to do is go to the cath lab and take care of it, okay? So if you see an NSTEMI like this person has, right, I think this is just kind of an introduction. This whole field is complicated and difficult, but if they have acute coronary syndrome, you really kind of want to basically look at, well, are they in cardiogenic shock? Are they having electrical instability, meaning ventricular arrhythmias or heart block? Okay. Can you not get rid of their chest pain? Then we're going to go to the cath lab right away, even if it's an NSTEMI. Most of the time, though, you're going to be in this other kind of middle ground where they're older, they have lots of risk factors, maybe they got diabetes and a little CKD. And so we're going to try and take them to the cath lab in the first day or so. Okay. And if they're, relatively younger, have very few risk factors, we can kind of manage them with just medical therapy. Okay. And you can use the GRACE score. This is a score which is very widely available on your phone or any calculator out there. So anything over 140 is considered higher risk, and this is usually driven by age. Okay. So this is the TIMI risk score. Again, very available on any iPhone or whatever phone, and or risk factors that they have, the higher chance that they'll benefit from invasive evaluation, means a cath, plus or minus a stent or cabbage, depending on what we see. Okay. So your job is to recognize the MI, treat them with the anticoagulant, antiplatelet therapy, get their chest pain free, get cardiology on board, whether or not it's a cardiology service or not. And we can help with the patient and you guys decide what to do about intervention or not. Okay. So same case, 10 p.m., you get the night shift. Congratulations. Okay. So they're doing fine for 10 hours or so, but now they're complaining of more chest pain tightness. Okay. So again, we want to get the old ECG, ask them to get a new one, and go see the patient. Okay. All right. Does anybody want to take a guess what we see here as the most important kind of finding? I would say there's two important findings. So one, patient's now tachycardic, right? Sinus tachycardia is always a concerning finding. Okay. So this is lead two. So we're going to use a rhythm strip. You have upright P waves and a pretty consistent PR interval. And now the heart rate is probably around 135 to 140. Okay. So it's a little bit wider than two big boxes. Obviously now we have ST depressions, which are horizontal, or downward sloping, which are always abnormal and concerning. Okay. They're on multiple leads throughout the ECG. Okay. So this is concerning. And the patient has severe chest tightness now. They're tachycardic. Okay. Their stats are okay. Their lungs are clear. Well, we want to give them nitroglycerin. Why would we want to do that? Well, we want to relieve their chest pain. Okay, having this tachycardia is just making their ischemia worse. So when you're in trouble in a cardiac issue, often your symptoms and other factors can make things worse. So you want to decrease the angina, decrease the ischemia. Now, clearly they're hypertensive, so you don't need to worry about shock, right? Let's give them that metoprolol, okay? And if need be, you can give them morphine, okay? Morphine is not ideal first line agent, but it's also a good adjunct, okay? And if you're having to give more chest pain, they're going to need to go to the ICU, or maybe you're already in the ICU and you're going to give them IV nitroglycerin. IV nitroglycerin is not special. It just is titratable and you can go high on it, okay? Sublingual nitroglycerin are actually big doses of nitro. You can give nitro paste. It's not really adjustable. So that's really the only benefit of IV nitroglycerin is that you can go up rapidly, okay? Sublingual nitroglycerin are big doses, and so you can go up. And really, you titrate up to chest pain and blood pressure. Okay. Often limited by headache. Okay.
We do, sorry, pause. We do have some great questions happening. One,
Great.
yeah, so one, we'll go back. I think one is, do we need to worry about possible RV infarct in this situation as well, with regards to starting the nitro? Can we be reassured by lack of ST depression in the inferior leads, although it looks like there may be T-wave changes there too? And then Kyle similarly asked, what would you do rather than nitro if this was an RV infarct?
So if all good questions, right? So in general, if you see ST depressions, then you're not having it's hard to localize what's happening, right? We can't say for sure what vessel it's in, we just know it's severe. And we're gonna see probably a proximal LED lesion because it pretends a lot of heart muscle, right? But we don't know that for sure. Um, if you want to make sure that there is no STEMI and RV infarction, you can do a posterior ECG or a lateral ECG, which means you're just wrapping the ECG leads around the left chest and the left back under the scapula. And if you see ST elevations out there, then you have a lateral or posterior MI. That's pretty uncommon, but it's something to think about. For this case, I would not be worried about a ST elevation MI here, and I think all the therapies are very reasonable. If we have an RV infarct, um, honestly, the data is really hard. So if you know for sure that they have an RV infarct, and you have symptoms or signs that you're worried about RV infarction, this patient's going to be quite ill. And so they're going to go to the cath lab probably for early intervention. And so I would focus, if you know they have RV infarction and you know that they're in trouble with that, then I would suggest probably morphine, probably getting them to the cath lab sooner rather than later. I agree if you know for sure, avoid nitrates. But most of the time, you just don't know. Okay.
Yeah, and sorry,
Uh,
to clarify, so that sounds like if there were the inferior leads had ST depressions, that would be more concerning.
you cannot always differentiate that. So if, for instance, like we had an echocardiogram and the RV function was very poor, or all of a sudden they had jugular venous distension, which suggests RV infarction or hypotension. Um, and that's often quite complicated to read. So I think my first thought would be if it's clearly not an ST elevation, clearly not an inferior ST elevation, MI, everything you can do. If you know ahead of time you have RV infarction and there's concerns for hemodynamic issues, then that patient goes to the cath lab, right? And I'm thinking you're going to be giving a little bit of morphine and you're going to be working with cardiology colleagues about what to do.
Okay, thank you.
So I think the point of this case is to recognize that not all ACSs are one, stable in the sense that, they're chest pain free now, great. But I'm sure Emily can attest that, lots of patients get admitted overnight, feel good, and then stuff happens, right? You just don't know. Okay.
Okay, sorry. One last question for case two. In the end semi situation, so like I think the first prompt before the patient decompensated, is there a blood pressure that would give you pause at adding a at adding the beta blocker, i.e. 90/60, or would you just reach for a faster on, faster off beta blocker?
So I think that you'll get a lot of different answers to this question. So beta blockers are not strong blood pressure medicines, number one. Number two is if have good contractile function, you're not in shock. Again, beta blockers are very poor blood pressure medications, which is why they're like fifth line, okay, blood pressure agents. So unless they're truly hypotensive, then I would not worry about giving them a beta blocker. And I would choose an oral agent with a longer half-life because it's not going to peak and have an effect and then drop. I know it might sound a little bit opposite, but I want a nice low level of beta blockade. Sure, it lasts a little longer, but honestly, you're not going to get as much of a peak effect. And so if you're worried about hypotension per se, it's less likely going to happen. And let's say you're wrong. Well, a little bit of dobutamine or a little bit of intervention goes a long way with a little bit of beta blocker. Okay. But if they're having active ischemia and they're not hypotensive, then use that beta blocker to control their angina. Thank you. Okay, so now you're at the VA, and sometimes at the VA on the weekends, it's kind of like a ghost town, right? It's hard to get stuff happening. All right. So you're in the emergency room. You have a 58-year-old with diabetes, hypertension, rheumatoid arthritis. So right away, I want you to be thinking, okay, this patient certainly could have acute coronary syndrome, right? Rheumatoid arthritis is an inflammatory condition which increases the risk of acute coronary syndrome, males, females, okay? So that's always kind of not a clear, obvious risk factor. It's one of the other um, less classic risk factors are autoimmune diseases. Okay. This person's never had chest pain, doesn't have any coronary artery disease that we know about. Um, and then importantly, when you get a history, this is the history you get. It hurts, okay, and it just happened at rest, so that's why person came in because it was weird and new. It's constant, it's sharp, and it's stabbing. So we look at the chest X-ray and the ECG. I would advise you guys, just like you're going to look at your ECG or your chest X-ray, so look at your ECG, okay? That's how you learn. So this is a thinner person. We can tell by that on the sides. It's an excellent breath. It's a normal cardiac silhouette, right? The heart shadow is about a third of the total size of the chest. We have clear costophrenic angles, and the lung markings all look very normal. So this is a pretty normal chest X-ray. And then we have an ECG. Okay. Any questions or any comments or thoughts about the abnormalities on this ECG? Anybody have any diagnoses?
There seem to be global ST elevations.
Okay,
Me wonder more about pericarditis.
great. I love it. Okay, so thank you for sharing. Now, if you look, there's definitely pretty impressive ST elevations, and hopefully, as soon as you see this, you're like, oh no, right? This looks bad. However, where's the MI? Is it septal? Is it anterior? Is it lateral? Is it inferior? It's not really possible to have an MI everywhere, right? Especially somebody with normal vital signs. Okay. So again, your impression of what's happening is super important. Okay. Now, what's the characteristic of the ST elevations? You have this nice little kind of upward trending, right? ST segment starts here and goes up to there about, right? It's kind of upward, smiley facey. And then to hammer it home, we have these PR depressions, okay? Do you see how the PR interval is much lower than this TP segment? Okay. So again, that's why you don't use the PR interval, okay, as the baseline. This is the baseline when everything is electrically quiet. So there's PR depression. Okay. So I think we have a good idea of the diagnosis, right? Their vital signs are good, very normal. Okay. How often are you going to hear an abnormality, okay, in this syndrome? We'll talk about that. Okay. So what's our treatment strategy?
All right, we've got about 16 responses. Keep going, people. Okay. Here you go.
Okay. So I want to give them ibuprofen and colchicine, right? So we're treating pericarditis, okay? Labs are going to show up. It'll take a little while and they have a little bit of inflammation, okay? So these are obviously never specific, but this also will help clue you in a normal troponin, okay? It's the ECG and the presentation that I want you to focus on. Okay, the sharp chest pain, they don't look that ill. It's positional, meaning they can take a deep breath and you have chest pain. Okay, you're not going to be able to palpate it with a region, it's just going to be substernal. Okay, but it should have a pleuritic nature. You're going to see inflammation. That's why your ESR and CRP are going to be high. Now, you can get an echo, but again, if they're doing great, there's no reason to get a stat echo. The reason to get an echo is to look for a pericardial effusion, of course, right? Often there's going to be a pericardial effusion, but unless they're hemodynamically unstable or more short of breath, then there's not going to be any evidence of tamponade, okay? So I think an echo is helpful to kind of risk stratify this person, but you really want to start ibuprofen and colchicine. And the dose of colchicine is with somebody who's a normal size, normal kidney function is going to be 1.2 milligrams now, and then 0.6 milligrams twice a day. It's a pretty high dose of colchicine, okay? And usually GI distress or diarrhea is going to be your issue, okay? If you have impaired renal function, then you give a lower dose. Colchicine works remarkably quick, okay? It's pretty impressive. Usually hours to a day or two, it can help. High dose NSAIDs, right? Ibuprofen 800 milligrams 3 to 4 times a day. This isn't your normal kind of low dose NSAID. This is very high dose NSAID because the pericardium is super inflamed. We want to give anti-inflammatories. Okay. And we're going to give colchicine for several months, okay, at least 3 months. And then typically we'll give ibuprofen for at least a month, if not longer. Okay. Now, this person probably has a autoimmune related pericardial inflammation. And so you might start thinking about steroids, but that is usually more something where you're going to get lupus associated serositis, where all your other markers of active lupus flare are going to be abnormal. So if you're just dealing with idiopathic or viral pericarditis, you want to avoid steroids, okay? Unless you're kind of using or partnering with rheumatology colleagues and we're treating something that would benefit from steroids, you really want to avoid them, okay? There's not hard data. There's observational data that using steroids actually can increase the chance of having chronic pericarditis, which is not something that anybody wants to have. It's a miserable condition, okay? Lots of etiologies for pericarditis. Most of the time it's we don't know, okay? Um, and then a lot of other times it's going to be a viral infection that they had, all right? So Coxsackie viruses, influenza, COVID, lots of viruses, okay? Bacterial pericarditis is very rare, except for tuberculosis outside the US. These are patients who are in shock from sepsis, okay? Because you have a bacterial infection in your mediastinum. And then you have a bunch of other causes. Probably the most ones you're going to be seeing are going to be renal failure with uremia, malignancy, either due to direct cancer involvement or due to treatment effect, okay? So you're going to get typically shark and pleuritic symptoms relieved with sitting up, okay? ST elevations that are diffuse, many leads, they don't really respond to any contiguous segments, up sloping ST segments. You're not going to get that reciprocal ST depressions, okay? So all of these are going to be kind of things to think about. And then, the less concerning things you'll see for pericarditis is going to be these upsloping ST segments, as opposed to the other things you'll see for ST elevation MI. And then also don't take your kind of overall clinical gestalt out of the picture. Okay. So high dose NSAIDs, ibuprofen, colchicine, and avoid steroids. Okay. Any questions about that one? You're going to see it. It's going to be quite common. Often the ECG is not that impressive. Okay. You need 2 of 3 symptoms or 2 of 4. You need evidence of an effusion, chest pain, inflammatory markers, or ECG changes. So you don't need all of them. Okay. So pericarditis is something that you will see. Sometimes it's hard to diagnose. Okay. So let's move on. So now you're in the UW, you're in your ER rotation, okay? The 42-year-old, okay? On the board, it says ACS rule out. So your attending tells you to go see the person, okay? There's no past medical history, but they have severe retrosternal chest pain. It's radiating. It began 3 hours, but it's still really unrelenting, okay? Those are concerning symptoms, right? Okay. So quickly review the chart. Okay, this isn't where you take a half an hour deep dive. Okay, this is where you spend about 2 to 3 minutes or so. Okay. In that meantime, the nurse should be doing, or somebody should be doing ECG, right? Getting their vital signs. Okay. So this is somebody with concerning vital signs, right? They have hypoxemia, they're tachycardic. Okay. Hypertension is not always a reassuring symptom. Okay. They're in discomfort. JVP is a little elevated. They have a diastolic murmur at the right upper sternal area. Okay. They have crackles in both lung fields and their extremities are cool. So what's this look like? I hope it makes you anxious when you see this patient, because this person, it seems like they're in shock, right? They have pulmonary edema, right? So this is usually acute. Their extremities are cool, so they're not perfusing. Okay. JVP is elevated and they have this weird murmur. Okay. Okay. Let's look at the ECG. So sinus tachycardia, again, always concerning. And then we're going to see these pretty impressive ST depressions. Okay. You also have this maybe ST elevations here, but again, it doesn't really meet criteria. Okay. So it has to be 2.5. Okay. You are seeing this ST depressions here. So I would be worried about an ST elevation MI or ischemia. We get that chest X-ray. Clearly different than the other one we've reviewed. Poor lung inspiration, right? When you're ill, you're not going to be taking the biggest breaths. There's diffuse bilateral opacities, which are concerning for fluid. You have what looks like cardiomegaly, although this is likely an AP film. And you have this pretty big aorta. And then you could see it going down here, right? Labs, you have an elevated natriuretic peptide, an elevated troponin, and an elevated D-dimer. Okay. Now we're running out of time, so let's put your guess out.
All right.
Okay. So I like the choices. The answer that I was going for was order a stat CT, okay? And the reason why is that because I don't think we have a firm ST elevation STEMI diagnosis, and we have potential alternative lethal things going on, right? The treatment for a thrombosis, either a PE or an MI, is this stuff, right? We don't want to be doing that if somebody has something else going on in the chest, right? A acute aortic dissection, right? So this person got a CTA. This is the dissection flap, okay? So the aorta, the intimal wall rips, and now you have a dissection, okay? So this is an ascending aorta dissection, okay? Because here's the pulmonary artery, so you're in the inferior, and you're in the mediastinum still, right? Right in the heart. And you really want to do a CTA, okay? If for whatever reason you can't get a CT, then you can do a TE. This is uncommon, okay? And then the MRI, I think, is helpful for just surveillance of the aorta. Okay, you want to get that CT. Now, because this person had, lots of the differential was going to be a little larger, you're going to talk with your radiology colleagues and say, hey, this person's quite ill. We need to look for a dissection and a PE. Okay. And thankfully, the contrast is in the pulmonary artery too, so we can tell both. Okay. Unfortunately, you know, in acute dissection, you're not going to be getting very obvious ECG changes, okay? You might see some acute changes, but a lot of times it's normal, okay? And this is just a series of ECGs. So there really isn't any, take-home point for ECG changes in acute dissections, okay? So people who have chronic untreated hypertension, known athero, bicuspid valves, okay? These are going to be your three probably most common causes of aneurysms, okay? A bicuspid valve is a congenital heart disease. It's one of the more common forms of congenital heart disease, and it predisposes to aortic dissections, especially at younger persons and at smaller diameter. So if you know they have a pre-existing aneurysm, okay, and it was 4.5 centimeters, let's say, no big deal. Well, they come in with this presentation, it's dissection until proven otherwise, okay? Just because there's a cutoff for screening doesn't mean that they can't rupture sooner, okay? Those are just guidelines. And then if they have other genetic syndromes or other findings, like inflammatory diseases. So the aorta, we roughly break it up into the ascending aorta and everything else, right? Okay. And I would focus on kind of type A and type B, right? So type A involves the ascending aorta. This is a medical emergency. You need to go to the operating room, okay? Again, this is one where minutes count. Type B is totally different. You're not going to die from a type B dissection, okay? You could have catastrophic complications though, because it infarcts your small bowel or your kidney. but you're usually not going to die from that. Okay, so it's a case by case basis. Type A is different. So how are we going to medically manage this person? I know we're running out of time, so we'll just finish up.
I might just let you reveal the results since we're at
Okay, I'm
yeah.
sorry. Okay, so the important thing to do is slow the heart rate down. Okay, so this is going to be for type A dissections while they're going to the emergency room, or type B, okay, and you're managing overnight, right? You don't want to give IV hydralazine. You want to give beta blockers, either labetalol or esmolol. This person's going to be in the ICU. Going to get their blood pressure down, get their heart rate in the 50s. And if need be, you can add other agents, okay? Nitroprusside or nitrocardipine. All right. This person had they had a MI because you had a dissection of the right coronary artery. And that can happen because the aortic wall rips and then you get a flap and then it can occlude the coronary artery, okay? So this is what happens. The dissections can go up to the brain or down to the heart. There's nothing that says it can't go both ways, okay? And so this person had an aortic valve regurgitation, they had acute infarction, and they had a type A dissection. And the treatment is to call cardiothoracic surgery. Okay. Okay, so I want you guys to think about, okay, stable or unstable, super important, and you need to do a focus history. It needs to be focused and quick. Okay, look at your old ECGs, get new ones, and review all your imaging so that when you call us, we can have an informed discussion. Right? Okay, I know I went a couple seconds overboard. I apologize. Thank you for that participation.
Yeah, thank you so much, you guys. I think it was great participation in the chat and with questions. Any questions for Dr. Ferris, please shout them out. And otherwise, we definitely appreciate the evaluations from the QR code. And thank you for your time this morning. But we'll hang tight for another couple minutes for any questions.
And I just put my email in the chat if you have any questions about the cases or whatever. Colchicine dosing, sure. Bear with me. Okay, so we're going to give colchicine for a few months, okay? And if you're worried that maybe they're still having chest pain, you can continue this, okay? You can also go to 0.6 milligrams once a day. It doesn't have to be high dose and then stop it, okay? But the clinical studies that have been done with colchicine are high dose for a few months. Swathi, I hope that helps.
Yeah, thank you so much.